In critical care, some moments are just make or break. Everything comes down to a single procedure. And maybe none is more fraught with danger than securing a patient's airway. It's often called the most dangerous minute in the ICU. It's a high-wire act where a patient's fragile condition can turn a life-saving intervention into a total catastrophe. But just how high are the stakes, really?
Okay, let's just cut right to it with a number that should really make you sit up. 45%. That is a staggeringly high figure, and it represents the risk of something going terribly wrong.
And look, we're not talking about some minor hiccup here. This is a nearly 1 in 2 chance of a major, life-threatening complication happening. We're talking about a patient's blood pressure completely bottoming out, their oxygen levels plummeting to critical lows, or even a full-blown cardiac arrest. So to really get why this happens, we've got to break down what's actually going on during this incredibly high-stakes procedure. So if we look at the data from this huge international study called INTube, it really breaks down what goes wrong. When a complication does happen, the biggest problem, by a long shot, is cardiovascular instability. We're talking over 42% of the time. Severely low oxygen, or hypoxaemia, and cardiac arrest are also major risks. The key takeaway here is that when things go south, it's most often the patient's circulatory system that fails first. All right, so why is this happening? What's the deal? To understand this, we have to go beyond just the physical act of intubation and really navigate what's known as the physiological minefield of a critically ill patient. And this brings us to a really important question. You might be thinking, wait a minute, people get intubated for surgery in the OR all the time. So what makes doing it in the ICU so incredibly dangerous? Well, the answer is all about this concept, the physiologically difficult airway. And this is a huge shift in thinking, really revolutionary. You see, for a long time, a difficult airway just meant a physical problem for the doctor, like they couldn't see the vocal cords or something. But here, the difficulty isn't about anatomy at all. It's about the patient just not having the reserves to handle the stress of the procedure. So here's the simplest way to think about it. Anatomical difficulty, that's the doctor's problem. It's, I can't get the tube in. But physiological difficulty, that's the patient's crisis. It's, my body can't handle this. This is a completely different kind of challenge with way more immediate and dire consequences. Okay, so let's dive into that first and biggest risk in this physiological minefield, cardiovascular collapse. So why do their blood pressures just tank? Well, it's not any one thing. It's a total perfect storm of factors all hitting at the absolute worst moment. A collapse happens when two forces basically slam into each other. On one side, you've got the patient who's already in a really bad state. Maybe they're in shock, low on blood, or their heart is weak. And on the other side, you've got the effects of the procedure itself. The anesthetic drugs make blood vessels relax, and the ventilator pushing air in can actually reduce blood flow back to the heart. When you hit a weak system with all those stressors, collapse is almost inevitable. And this is where we get to something really crucial, something doctors can actually control, the choice of drug. Propofol is super common, but man, it is notorious for tanking a patient's blood pressure. That's exactly why modern guidelines are leaning towards drugs like ketamine or etomidate. They're just much gentler on the patient's blood pressure and circulation, and that gives them a vital margin of safety. All right, so we've talked about collapse, but beyond that, there's a second huge danger here, and it's basically a race against the clock for oxygen. The whole procedure really is ruled by this one concept, safe apnea time. So the second you give the drugs and paralyze the patient, they stop breathing. That's when the clock starts ticking. How long do you have before their oxygen level just falls off a cliff? And this right here is where the difference between a healthy person and a critically ill patient is just terrifying. A healthy person has a big oxygen reserve in their lungs, which might give a doctor 8 minutes or more. But a critically ill patient with sick, maybe fluid-filled lungs, they have almost no reserve. Their safe time might be less than 30 seconds. 30. There is zero room for error. So obviously, you have to do everything you can to stretch out that safe time. And modern techniques make a massive difference. Studies show that just using a standard face mask, well, a lot of patients still end up with dangerously low oxygen. But if you switch to something like non-invasive ventilation, or NIV, which actively helps them breathe before you start, you can cut that risk by more than half. That's huge. And if all of this wasn't high stakes enough,
These risks are just magnified when the patient is a critically ill child. Their own physiological reserves are even smaller, and a lot of times this has to happen in hospitals that don't have a specialized pediatric ICU, which just raises the stakes even higher.
Just think about this number for a second. 1 in 160. That's the rate of cardiac arrest when anesthetizing these little kids in hospitals that aren't pediatric specialty centers, before the transport team can even get there. And what's the number one cause? The exact things we've been talking about: low oxygen and airway problems. It's that same physiological minefield, but with a patient who has even fewer reserves to begin with. And, this quote from the UK's National Audit Project really just says it all. It captures the incredible pressure these medical teams are under. It really highlights how daunting and emotionally heavy these moments are, not just for the patient and their family, but for the doctors and nurses right there at the bedside. But here's the good news. This story doesn't end with just listing the problems. Over the last 10 years or so, a much deeper understanding of all this has led to a whole new playbook for making this procedure safer. This new modern playbook is basically a checklist, but it's built around physiology first. 1, you optimize the patient before you even start. You treat that low blood pressure, you get their oxygen up. 2, you use smarter tools like NIV or high-flow oxygen to build up a bigger oxygen reserve. 3, you pick your drugs carefully to avoid that circulatory collapse. And 4, you use technology like videolaryngoscopy to make sure you get the tube in on the first try, minimizing that dangerous time when the patient isn't breathing. So, the crucial takeaway here is this. It's all about a shift in focus. It's about moving away from just the mechanics of the procedure and instead having a deep, deep respect for the patient's fragile physiology. This new approach transforms one of the most dangerous minutes in medicine by anticipating problems and using a smart, evidence-based strategy to navigate that minefield safely. This really has been a massive leap forward for patient safety. But it also leaves us with a really exciting question for the future, right? As our tools get even better and our understanding of critical illness gets more and more sophisticated, just how safe can we make this one critical minute? What new strategies will emerge to protect the next generation of critically ill patients?